Today, I am tasked to discuss a topic on geriatric anesthesia entitled The Physiology of Aging and Improving Perioperative Functional Capacity. In our everyday life, we always give special attention to children because children are not little adults. But how about our senior citizens? Are they just simply older adults? The objectives of this lecture are the following. In 2015, the Philippine population was about 100 million plus, and 7.5% of these are senior citizen. Senior citizen is defined as any person aged 60 years old and above by the Republic Act 9994, Section 3A. Worldwide, 461 million people aged 65 years old and above was recorded in 2004 and is estimated to increase to 2 billion in 2050. The shift in the population demography creates a greater challenge to the medical practitioners because it is estimated that 50% of this population will undergo surgery. With the advancement of the chronological age, comorbidities are not unusual. With multiple chronic health conditions, they are in multiple drug therapy as well, which further increases the possibility of morbidity and mortality. With multiple chronic health conditions, they are in multiple drug therapy as well, which further increases the possibility of mortality and morbidity. Understanding the physiological and anatomical changes help minimize debilitating operative sequelae or avoid untoward circumstances such as death. This slide shows the physiologic changes of aging and its clinical implications. These are the systems and organs that has an impact in the practice of anesthesia. In general, aging results in increase in body fat, decreased lean muscle and strength, and growth hormone, leading to decreased lipolysis and accumulation of body fats. The decreased energy consumption leads to hyperglycemia, hyperlipidemia, and other metabolic problems. Most of them are devoid in protein. The cardiovascular changes are directly related to the stiffening and decreased sensibility of the systemic arteries and cardiac muscle walls. A decline in cardiac output causes delay in the absorption, onset of action, and elimination of medications. Aging heart is in a relative hyposympathetic state. Therefore, increase in cardiac output is dependent on the increasing the stroke volume, not by increasing the heart rate. The decrease in the elasticity of blood vessels increases peripheral vascular resistance, elevation of systolic blood pressure, and left ventricular hypertrophy. In response to induction agents, exaggerated effects on blood pressure can be seen. A decrease in the atrial pacemaker cells also decreases heart rate with decreased responsiveness to atropine. Responsiveness to beta receptor is as well decreased. Therefore, in hypotension, alpha agonists such as metaraminol should be the pressor of choice. The decline in the pulmonary function test depends on the peak lung function achieved during adulthood. The progressive decline in the functional capacity decreases ability to deliver oxygen. Anatomical or structural changes decreases chest wall compliance, resulting to difficult lung ventilation. Elastic recoil of the lungs decreases with collapse, resulting to air trapping and eventually to ventilation perfusion mismatch. The decrease in the strength of respiratory muscle causes changes in lung mechanics to decline in maximum inspiratory and expiratory force. Ventilatory responses to hypoxia and hypercarbia fall by 50 and 40% respectively due to the declining chemoreceptor function. There is a progressive decrease in T cell functions, mucociliary clearance, and decrease in swallowing functions, which predisposes elderly to aspiration. Difficulty of bag mask ventilation due to loss of facial contours as a result of alveolar bone resorption and loss of dentition. Decreased number of alveoli with increased size may impair gas exchange. Blood oxygen content decreases by 10 to 15%, but carbon dioxide levels remain unchanged. Post-operatively, age-associated muscular weakness reduces ability to cough forcibly and remove secretions effectively, which may lead to pulmonary complications. The Arozola Multifactorial Risk Index is used in predicting post-operative pulmonary complications. So you can access this online, and the higher the value, the more likely the patient will develop pulmonary failure. The decrease in renal function is primarily due to the decrease in renal blood flow as a result of the decrease in cardiac output. There is a marked decline in the subjective feeling of thirst, probably due to the alteration in the chemoreceptor functions in the hypothalamus, for they do not respond to the elevation in serum osmolality. Volume overload can occur because of the functional impairment of the diluting segment of the nephrons, or associated elevation of antidiuretic hormone in the postoperative period. Decreased renal function is responsible for prolonged action of relaxants and morphine. This rule of thumb is useful in assessment and treatment of fluid and electrolyte disturbances in elderly surgical patients. With the advancement of age, hepatic function affects drug metabolism and eventually excretion of drug dependent in the liver for metabolism, such as fentanyl and vecuronium. After age 60, hepatic blood flow decreases by 1% per year. Furthermore, decreased gastric motility, increase in gastric pH, decreased hepatic blood flow, and liver mass with decreased hepatic microsomal enzyme function affect the drug pharmacokinetics. Elderly patients are prone to aspiration and delayed absorption of oral medications because they have delayed gastric emptying time. In the CNS, age-related changes affect cognitive, sensory, and autonomic functions. These problems make elderly patients to easily enter into the state of confusion following any form of stress. If these problems were uncontrolled, autonomic dysfunction can blunt physiological compensatory response to hypotension and thermoregulation. Shivering will require more oxygen, the demand which cannot be handled by aging heart and lungs. Prolonged effects of anesthetic and other adjunctive medications makes elderly patients prone to develop hypothermia. Frank discussion with the family members on POCD, which occurs in 15 to 50% of post-operative elderly patients, is very important. According to American College of Surgeons National Quality Improvement Program, 19% of death occurs within 30 days. With an expected 350% increase in the old population segment by year 2050, surgical morbidity is predicted to increase by 27%. With proper preparation, safe surgical and anesthesia intervention is highly possible. This is the flowchart of McGill perioperative system to prepare patients for surgical preoperatively. Rehabilitation clinic is a multidisciplinary process. It is the process of expanding patients' functional and psychological capacity to reduce potential deleterious effect of a significant stressor, which is the surgery itself. This program satisfies the re-engineering system of perioperative multidisciplinary protocols that aims for successful surgical outcome. The objectives of rehabilitation clinic are the following. It is directed to prepare patients physically, emotionally, and psychologically. It could be unimodal or multimodal system. This is an example of triple modal rehabilitation program consisting of physical exercise, psychological well-being, and nutritional organization with their respective goals. This is another multimodal rehabilitation program which includes health optimization. In physical exercise activities, the modified Berg-Disney scale can be used to assess patients' tolerable level of physical activities. Psychological support can be done with the use of relaxation techniques such as breathing exercises, cognitive behavioral therapy, guided imagery, and problem-solving and coping strategies with clinical psychologists. The preoperative nutrition scoring can be used to guide clinicians and nutritionists to assess and manage the nutritional needs of the patient. Elderly are devoid of protein. To stimulate muscle protein synthesis, leucine-rich dietary protein or the whey protein can be given after a bout of resistance exercise to support muscle protein synthesis. This is another rehabilitation program with specific diagnostic and treatment options. Studies showed that patients who were subjected to rehabilitation program had improved quality of life post-operatively as compared to those who did not. In implementing rehabilitation, a 3 to week duration is recommended to increase functional capacity by 2 to 10%. Adjuvant treatment can also be started, while those who are already in adjuvant treatment can just continue with it. Before giving surgical advice to patient, a physician must consider all these considerations. In general, assessment of elderly patients is just the same as the younger individuals, but with special focus on the following. First, in assessing cognitive condition, look for the signs of delirium, dementia, and depression. Delirium is the state of acute confusion, inattention, and altered level of consciousness and disorganized thinking. Controlling the risk factors decreases the occurrence of delirium. Some of these factors can easily be managed, like dehydration and modification of medications. The presence of number 1 and 3 in the key criteria plus one of number 3 and 4 is diagnostic of delirium. Depressed patients result to poor functional capacity. Studies showed that they were usually discharged to facilities after surgery. This problem usually causes prolonged duration of delirium. The capacity of patients to make decisions must also be assessed, especially to those who have had assessed with cognitive problem. Patients must present these elements for acceptable decision-making capacity. Functional assessment is important to determine the needs to refer patients to occupational and/or physical therapists. Fall is a common accident and cause of death in geriatric population. If cardiorespiratory reserve reflects functional capacity, frailty reflects the diminished physiologic reserve across multiple organs and therefore a sign that the patient cannot tolerate physiologic insults. Studies show that frailty is an independent factor to consider in surgical patients for an increased mortality and morbidity. There are two categories, the physical and multi-domain frailty. Physically frail patients should present 3 or more of these clinical presentations, whereas the multi-domain frailty is more of the emotional aspect of the patient. Frail patients have narrow physiologic parameters such as in fluid therapy. Nutrition should be assessed to predict possible dehiscence, anastomotic leak, infection, delirium, increased length of hospital stay, and possibly death. Consider the possibility of withdrawal syndrome in patients who are still on regular alcohol intake or tobacco use. A recommended 48 weeks of alcohol abstinence can be achieved with or without pharmacological strategies. Elderly are said to be in a polypharmacy state, and a review of medication is important, including OTC medications, because some of these medications may cause adverse effect, drug-drug interaction with anesthetic, or may cause withdrawal. The Beers criteria is screening tool of older person prescription or the stop and screening tool to alert doctors to right treatment or the start can be used to determine inappropriate medications. Cardiac and pulmonary risk is the central component as MI is the most common cause of in-hospital death among elderly surgical patients. The ACC and the AHA guidelines recommends preoperative cardiac testing judiciously and to avoid unnecessary testing. If pulmonary testing and optimization is not complied, pulmonary complications is very common, especially to those with or still in these conditions. Different assessment tools are available online. The Charleston Comorbidity Index is a method of categorizing comorbidities based on ICD. This medical calculator predicts 10-year survival in patients with comorbidity. This can be downloaded online. And recently, a question on COVID was added, but is still on research purposes. Answer does not influence the result yet. Here are the list of different assessment tools that can be used in comprehensive geriatric assessment. In the last few years, ERAS protocol has been introduced to surgical team members. Studies show that ERAS protocol reduced 51% of post-operative complications, especially if coupled with rehabilitation. It aims to reduce organ dysfunction and surgical stress response and length of stay without associated increase in mortality, complications, and readmission. Anesthesiologist plays a very important role in implementing the ERAS protocol. Pre-admission, anesthesiologist works with the internist or family physician to optimize medical conditions. In pre-operative fasting, a 2 to 3 hour intake of clear fluid does not present any danger as the nothing per hour for 8 hours. Give PONV prophylaxis. Intraoperatively, regional anesthesia is preferred because it can be facilitated without the use of opioids. A balanced fluid therapy is recommended and strict thermoregulation. Post-operatively, multimodal opioid-sparing pain management is highly recommended. ERAS, according to European Society of Anesthesiologists, is an adjunct in the prevention of perioperative delirium. The National Surgical Quality Improvement Program recommends ERAS because of limited fasting, avoidance of the use of opioids, early mobilization, and early oral intake. In 2019, a meta-analysis showed that mortality and morbidity increases with age. However, in laparoscopic gastrectomy, the results were comparable with non-elderly patients. Whereas in pancreatectomy, the mortality was higher in elderly patients, but morbidity was the same, except that elderly were discharged to a rehabilitation facility. The question arises to whether surgery is associated with better outcome for the elderly patient compared with the conservative management. The fragile status of elderly patients, the anesthesiologist therefore should consider these factors in choosing anesthesia techniques. Anesthesia technique should adopt multidisciplinary approach. All anesthetic techniques can be applied, but combination is highly recommended and should be performed by the most experienced anesthesiologist. During pre-oxygenation, the 30-second technique is not acceptable because elderly easily desaturate. The linear decline of ED50 with age, the dose of CNS drug must be reduced. Expect hypotension and delayed effects of drugs. During maintenance, MAC should be decreased and expect for prolonged effects of neuromuscular blocking agents, except for atracurium and cis-atracurium because they undergo Hoffman elimination process. Despite of low in MAC, prolonged emergence is also expected. So gamma-dex is the drug of choice for NMBA reversal. Although opioid-sparing regional anesthesia is recommended, concerns with its use should be considered. In vasopressor therapy, the decrease in the beta receptor activity means there will be a decreased response to ephedrine and phenylephrine. This is the chart to guide us in the dose adjustment of anesthetic in elderly patients. This is available online. For monitoring, invasive arterial BP monitoring is highly suggested. Monitoring of hemoglobin concentration, arterial blood gases are recommended intraoperatively. The BP limit should not be lower than 20% from the baseline. At 15%, cerebral oxygen desaturation is indicative of cerebral ischemia. With the use of cerebral oximetry, early intervention can be instituted. To avoid excessive depth of anesthesia, BIS or entropy monitoring is highly recommended. The same way with NMBA monitoring to keep proper degree of neuromuscular blockade. Although goal-directed hemodynamic therapy decreases mortality and morbidity, it does not improve the preoperative cardiac performance. Neurologic complication is the most common complication in geriatric surgical patients. 15 to 53% presents as post-op delirium, especially those who underwent high-risk surgical procedure. Diagnosis is the same as in preoperative evaluation and as shown in this chart. This chart shows different strategies to avoid delirium. Management can either be non-pharmacological as the first line and pharmacological with the use of antipsychotic medication at the lowest effect dose as the second line treatment protocol. In pulmonary complications, the most common are atelectasis, hospital-acquired pneumonia, and acute respiratory failure. Pre-operative intervention like inspiratory muscle training, smoking cessation, and use of minimally invasive surgery technique prevents the occurrence of pulmonary complications. This chart shows different strategies to prevent pulmonary complications. In-hospital fall has recorded of about 700,000 to 1 million incidents yearly, 1.5% of which happened in surgical patients of average age of 64 years old. The risk factors are the following. This chart shows the universal fall precautions. And this chart shows the risk factors and assessment intervention to prevent falls. Malnutrition rate in post-operative patients occurs to about 38.7%. the safe early feeding postoperatively exclude elderly patients. This is the guidelines issued by the European Society of Clinical Nutrition and Metabolism to introduce enteral nutrition and identify signs of dysphagia. Postoperative functional decline has an incidence rate of 30%, in which 50% recovered 1 year after. Identification and control of risks and early intervention is needed to prevent this complication in elderly patients. UTI is the most common nosocomial infection in postoperative patients with an incidence rate of 32 to 40%. Implementation of strategies and daily review of indication of urethral catheterization is recommended in the prevention of this complication. Pressure ulcer is common in patients with long-standing comorbid conditions and those who are 70 years old and above. It is important to identify the risk factors for prevention and treatment. Discharge of elderly patients should be carefully planned and assessed before sending home. Inform family members the need, schedule, indications, and possible effects and side effects of the medications. Reiterate schedule of follow-up. Document clinical history and surgical events and outcomes. Before I end my lecture, I would like to share this to you. To care for those who once cared for us is one of the highest honors. Thank you and be safe.